Just start your camera and mic. Prashant sir.
Hey, okay.
Just 1 minute. Yeah, sir. Okay.
कैमरा बराबर कहाँ पे देखना है अपने को? यहाँ देखना है और ये पोजीशन बराबर इधर Hiremat sir, hi.
Hi.
Hi, sir. Dr. Sameer here. How are you?
Yeah, I am fine, fine. Sir.
Hi, Dr. Hiramat. How are you?
Hiremat sir is at home or is in the hospital?
Home.
Home.
There's nothing in the hospital.
Yeah, I know. What is did you also notice a fall in the STEMI patients in your?
Yes. But you know, it's like in Rubiol, it's very low. But my peripheral hospitals where I go, one of them is doing a roaring business.
Okay.
So it probably means that people are hating to travel and probably wanting to go to a nearby hospital.
We also did about 7-8 PAMIs in this month, in the month of April.
As usual or less or more?
Yeah, I mean, patients, Nagpur is a big city, but all the patients were from Nagpur only.
Did you have any COVID positive PAMI?
No, not yet. Till now, we have only 50 patients, around 50 patients in Nagpur, only one death, and most are asymptomatic. Most of them are asymptomatic. All quarantined and being admitted, but no.
But in all these PAMI cases, you find standard coronary blockage, or you
yeah. All out of this 8 PAMIs, one could not afford angioplasty, so we thrombolized, and angiogram showed a recanalized LAD. Rest all of them had a 99 or 100% lesion, and we had to do primary angioplasty.
So you're now lysing them, or you're still doing?
No, we are doing primary. Only one patient we lysed, because Nagpur is otherwise a small place. Connectivity is good, so our team is ready in 30 minutes. So there's no problem doing PAMI.
You wait for the COVID negative to come?
No, COVID results we don't get before 48 to 72 hours. We don't have a rapid test here.
PAMI is quicker.
PAMI is quicker.
The COVID reports.
Yeah, I know. So first 15 days we had no patients. Second half, first 15 days not many PAMIs, hardly one. But next 15 days lot have come. So I don't know what triggered these cases, or I have no clue.
So it's very difficult to conclude on the number, I feel.
But in Nagpur, the number of deaths which have occurred in this month are correspondingly less as compared to last year.
You mean COVID deaths?
No, deaths. Total number of deaths in Nagpur, data has been published in newspaper. So in second half of March and first half of April, the number of deaths are less this year compared to last year.
What can you conclude? I mean, you never compared Nagpur with Nasik.
No, but I'm talking about Nagpur. Nagpur, as I told, we have a WhatsApp group in which all the hospitals are connected, and you have to report to the NMC that is Nagpur Municipal Corporation, about any patient who is admitted with respiratory illness or is on ventilator. So last 10-15 days, I am following that WhatsApp group. Not a single patient of ventilator, forget about COVID. Very few patients of even fever. So those fever patients are referred to Government Medical College. And we have only 3 clusters in Nagpur where the patients are coming from. Only 3 areas. Otherwise, there are no stage 3 patients or phase 3 patients in Nagpur. We haven't seen.
You're lucky because Bombay and Pune, I think the number is still on the rise.
I think Nagpur, the lockdown was very effective because of the municipal commissioner and the collector. They were very aggressive. And they have done survey of 4 lakh people in Nagpur. House to house survey of 4 lakh people.
What?
House to house survey of 4 lakh people in Nagpur. They have done. Whether there is anybody who is ill, who has gone abroad, who has come recently. And all those quarantined in Nagpur, there was a policeman who was sitting outside the house. No, those people could not go out. So it was, lockdown was followed in spirit, in true spirit.
Yeah, Nagpur is important city. You understand what I mean?
Yeah.
Can you push my volume up? I can barely hear Prashant.
Okay. Can you hear now?
No, I don't think you can do anything. These people will have to do something.
Mm-hmm.
Yeah, I'll speak to the technical person.
So at the end of the lectures, the audience would put questions to you, Dr. Hiremat, right? And then you will ask us. Is it the way?
मैं ऑन किया, कैमरा भी किया, ये भी किया, बट अभी मेरे को प्रेजेंटेशन मेरा किधर से लाऊं मैं? ये को मिनिमाइज कैसे करते हैं? हाँ? Alter F10 ना? Alter tab. हाँ. हाँ, एक मिनट और. नहीं, मेरा प्रेजेंटेशन किधर गया? हाँ, एक मिनट. Alter tab. नहीं हो रहा है. समीर के पास है ना मेरा प्रेजेंटेशन. समीर हैज माय प्रेजेंटेशंस. समीर विल. नहीं किया है. ये जूम को कैसे मिनिमाइज करूँ ये समझ में नहीं आ रहा है मेरे को. विंडोज डी. हाँ, करेक्ट. एक मिनट, मैं खोलता हूँ मेरा प्रेजेंटेशन.
Good evening.
हाँ. क्या करना है? ऑल्टर टैब. प्रेजेंटेशन ओपन हो गया. एक मिनट लाइन रखो. प्रेजेंटेशन ओपन हो गया है और ऑल्टर टैब करूं. कुछ नहीं आया. ऑल्टर टैब नहीं आता. ऑल्टर टैब ऑल्टर दबाया, टैब दबाया, फिर जूम कैसे सिलेक्ट करूं? अल्टर टैब ऐसे छोड़ता हूँ तो सब चला जाता है. कैसे करूँ यार? कुछ नहीं दिख रहा है. खाली मेरे को मेरा प्रेजेंटेशन दिख रहा है. अल्टर टैब दबाया तो सब आता है. एक मिनट. हाँ, आ गया. क्या शेयर स्क्रीन का? हाँ. Okay, fine. Thank you. Bye. Hello, Samir.
Yes.
You can see me?
Actually, the welcome screen is there, so I can't see anything right now.
Okay. Dr. Hiramat, you can see me?
Yes, I can see you, but I don't think I can see myself.
You can hear my sound, my voice?
Yes, very well.
Yeah,
Okay.
your voice is clear, Dr. Bhupen.
So you tell me, Samir, when I have to start.
Sure. I'll just start the meeting. Okay.
Samir sir, you can start. Samir sir, mic on कीजिए, mic on कीजिए.
A very good evening to all distinguished colleagues. I'm Dr. Samir Muchala, heading the Medical Affairs for Cardiodiabetology Therapy Areas at Zydus Healthcare Limited. At the outset, I'm sure you all and your near and dear ones are safe and healthy. It gives us immense pleasure to invite each one of you today to today's webinar on CVD management in current scenario, with a special focus on acute coronary syndrome and shortness of breath. It is my honor and privilege to introduce Dr. M.S. Hiramat, the moderator for today's web talk. He actually needs no introduction. He is Director of Cath Lab, Ruby Clinic, Pune, and a pioneer of coronary intervention. Without any further delay, I request Dr. M.S. Hiramat to carry forward the academic proceedings and invite Dr. Bhupen Desai, followed by Dr. Prashant Jagtap. Thank you again and look forward for a high decibel academic feast. Over to you, Dr. Hiramat.
Yeah, good afternoon, everybody. When Samir first spoke to me as to this is what he was planning, I was not sure what's going to come up in that 1 hour or so. So I was trying to suggest cardiovascular acute emergencies, how they presented earlier and how they are presenting now in COVID days. Is there a difference? And to some extent, we will travel the similar paths, though Samir has fine-tuned my general broad thoughts. And we have two very prolific speakers, Dr. Bhupen and Dr. Prashant. And we will start with Dr. Bhupen. His introduction, Samir.
Yeah. So Bhupen Desai is a consultant cardiologist at Desai Heart Care, Borivali. He's a senior consultant cardiologist with a lot of publications to his credit. So I request Dr. Bhupen Desai to kindly start his presentation.
Hello. Can you see my slides?
We can see only you.
Slides are not coming. Just a minute. Let me share screen. Just give me 1 minute.
Yeah, Samir, all days feel like Sundays, isn't it?
हाँ कौन सा शेयर ये करने का बस हो गया आगे कुछ नहीं
You can see my slide now.
Yeah, we can see
Yes.
your
Uh, good afternoon, everybody. I am Dr. Desai, and today I am going to talk about Samir. Slides are not moving.
Yeah, I'll just take care of it.
Okay, it's moving.
Yeah, it's moving.
So today I'm going to talk about management of shortness of breath in COVID pandemic era. I hope you can hear me very well.
Yes.
Yeah, very well.
Okay. So what is dyspnea? Shortness of breath is defined in medical terms as dyspnea. It's nothing but the shortness of breath, which is a very common symptom affecting as many as 25% of patients seen in our regular daily clinical ambulatory practice. If you go to a clinic of a chest physician, almost 60% of patients will complain of shortness of breath or dyspnea. We are, as a cardiologists, are involved with this because sometimes they are overlapping. So overlapping clinical presentations and comorbid diseases like congestive heart failure and chronic obstructive pulmonary disease, they can sometimes make life difficult for cardiologists, and it requires a good clinical judgment to evaluate what are we dealing with. So causes of dyspneas are many. There could be respiratory, cardiovascular, neuromuscular, sometimes systemic disorders like anemia. And many times we see many young ladies, particularly in these days, after seeing this COVID news on TV, they all come with significant dyspnea and chest pain. They are mainly psychogenic. So we are not going to, we all know about this thing. Mainly it is COPD, congestive heart failure, pulmonary embolism, and psychogenic. So how to approach a patient of dyspnea in current situation? That is what I'm going to talk. So whether it is COVID related or non-COVID related, if you have a patient who comes to you with fever, with significant dyspnea and cough, so fever, dyspnea and cough, you must consider this in today's era as a COVID patient unless proved otherwise. You have to treat it like this because many times they can mimic like cardiac patients. So any patient who comes to you with shortness of breath, fever and cough, unless and otherwise proved, it is COVID in today's situation. This is what guidelines are there. How to deal with a patient of shortness of breath who comes to your clinic or in your hospital. You have to put this questionnaire to him. Has someone in your close family returned from a foreign country? Ask patient to write yes or no. Is patient under home quarantine as advised by local health authority? Yes or no. Have you or someone in your family come in close contact with a confined COVID-19 patient in the last 14 days? Or do you have fever? Do you have cough? Do you have sore throat? Do you feel shortness of breath? If the answer to all this question is yes, you must send them. So, if answer to this is yes, you must send this patient to a government-approved COVID hospital because you should not take into your clinic or in hospital because otherwise everybody will get infected. So this is the first questionnaire. This is our practice. We give this questionnaire to a patient who comes to our hospital, and once his answer is yes, we send them to a government-operated hospital. We don't treat this patient in our setting. What is the importance of shortness of breath in current scenario? Either they have to go to a government-approved hospital for COVID testing, or they have to call up in a call center. Many times we get a phone, sir, I'm having breathlessness, I'm having cough, I'm having fever. So I tell him not to move out of the home and call up in this approved call center, the number given by the government. On receiving the call at the call center, they will ask his name, age, gender, address, and everything, and to ascertain whether the patient is suspect case of COVID-19 or not. So they will ask you about the patient's symptoms. Ask whether the patient is suffering from fever, cough, and difficulty in breathing. These call center people have been trained for this, so they will ask all these questions. Whether patient has recently returned from a foreign country or not, or whether the patient was under home quarantine as directed by the local health authority. If the answer to this question is yes, they will tell him to wait at home and assess whether the patient is fit to be transported or not. If it is not fit to be transported, they will send somebody at home to collect the nasopharyngeal swab for the COVID testing. Otherwise, they will call him or they will direct him to a government-approved setup where COVID testing is possible. These are all ICMR recent guidelines. So, which is the second most organ affected after lung in COVID? We all know the COVID is primarily a lung infection. And what is the most common organ after lung? And we all know the common organ after lung is lung. It's heart. Heart is very commonly affected. We have not realized this now. Many of the initial people doctors who died were cardiologists in Italy and Spain, even in China. So they were wrongly diagnosed as a cardiac patient, and finally it turned out to be COVID patient. How COVID affects heart? It causes inflammation of the heart. As you can see that it is increased inflammatory response, autonomic tone disturbances, hypercoagulable state, anemia, and downregulation of ACE2 receptors. Also, it decreases cardiac and pulmonary function. It increases hypoxia. So there is a cardiopulmonary deconditioning and peripheral deconditioning. This all leads to myocardial injury and conduction system damage. So they do have a lot of arrhythmias also. So initially, once there is a myocardial injury, they can present like acute myocardial infarction or acute coronary syndrome because there is significant decompensated heart failure and acute coronary syndrome. They can present like acute coronary syndrome or they can present like heart failure secondary to myocarditis and may present with significant hypotension. Other spectrum of the disease is tachyarrhythmias, bradyarrhythmias, drug-induced prolonged QT intervention, and sudden cardiac death. But since we are discussing about how a patient has come to you with shortness of breath and how to deal with, so I will confine myself to a syndrome of myocarditis or a fulminant myocarditis presenting as an acute heart failure. So this was the first case of contagion complicated with fulminant myocarditis, which was recently published just last week on April 10th. This article has come. So how this COVID-19 patient presents, we will go to see these patients so that we have a clear-cut idea how they present. COVID-19 patient may develop severe cardiac complications such as myocarditis and heart failure. I've spoken about it. This is the first report which I'm going to share with you, which was complicated with COVID myocarditis. And mechanism of cardiac pathology caused by COVID-19 is still not very clear. It will require some more research to identify how it can affect cardiac vessels. So let us discuss about a real life case of COVID presenting as a dyspnea. And this was the paper which came last week. It was presented on 10th of April this month only. This was the first case of COVID-19 complicated with fulminant myocarditis, a case report and insight. This was presented by Chinese people from Shenzhen. And what it showed that, this is the clinical presentation. A 63-year-old male admitted with shortness of breath. He also complained of white sticky sputum, fever of 39.3 degrees centigrade and a chest tightness after a little bit of walking. There was no past history of any heart disease or hypertension. Allergic cough was there for 5 years and there was history of previous smoking. The blood gas analysis of this patient showed a pH of 7.0 for the significant acidosis, POT of 66 and saturation was 1.8%. There was significant elevation of troponin T. Level was as high as 11.37 grams per liter. And there was a diffuse myocardial dyskinesia on echocardiography with ejection fraction of 36% only. They also checked for CRP, which was elevated. Pro-BNP was also elevated. And the highest level of interleukins, they did interleukin 6 level several times. The highest was 272.4 picogram per ml. Besides, chest radiogram showed a typical ground glass appearance suggestive of pneumonia. So initially they thought it is a case of heart failure, but suspect they did a viral markers and all the viral markers were negative excepting for COVID. So this was a COVID-related fulminant myocarditis and X-ray corroborated this. As you can see from this X-ray, figure A is of X-ray. You can see that pneumonia-like picture. And B and C are pictures of the CT scan, which showed ground glass appearance, very strongly suggestive of COVID-related lung injury. So this patient had both lung injury as well as myocarditis. ECG showed sinus tachycardia with RBPP, but there is no evidence of any significant ST elevation suggestive of acute myocardial infarction because his troponin T level was very high, but still ECG was not suggestive of ST elevation. And you can see this over a period of time, his troponin T came down, his pro-BNP level also came down, but myoglobulin, which is a marker of myocardial muscle damage, remained persistently high throughout the course of illness. Bedside echocardiography revealed enlarged left ventricle. The size was 61 millimeter. Diffuse myocardial dyskinesia along with low ejection fraction and calculated ejection fraction was 32%. There was a significant pulmonary hypertension calculated by TR jet velocity. It was 44 millimeter of mercury. There was no decrease in right heart function. So it was mainly left heart failure and there was no pericardial effusion. Treatment regime was like any other COVID patients. This patient was very sick, so he required ventilatory support, high flow oxygen, lopinavir and ritonavir antiviral therapy was also given. Interferon alpha 1b was also given. He was also given steroid in the form of methylprednisolone. Immunoglobulin was also given. And to prevent secondary infection, he was given piperacillin tazobactam. And he had a renal failure also, so he was on a continuous renal replacement therapy. After treatment, the LVEF of this patient gradually recovered. It became 68%. The left ventricle and wall thickness returned to within normal limits. And the bedside chest film suggested there was no cardiomegaly and the lesion has subsided. Infection-related markers increased gradually from the 26th day. Septic shock was diagnosed. He developed disseminated intravascular coagulation with sepsis and gradually developed ecchymosis all over the body. Unfortunately, this patient died on the 33rd day of the hospitalization. So this was a real life case. He presented like acute myocarditis, acute heart failure, heart failure part improved, but eventually died of secondary to sepsis, secondary to COVID infection. So what are the insights we got from these patients? COVID-19 can present with Fulmina Myocarditis. So we should always suspect this. It is the breathless, shortness of breath is not always related to the lung. It can be secondary to heart failure. Heart is the second most and secondary target organ after lungs in the COVID infection. Not only presents with abnormalities in the markers of myocardial injury, but also structural and functional damage. Sometimes we get carried away because troponin T is so high that this patient is suffering from acute coronary syndrome. And many of these patients underwent angiography and found to have normal coronary angiography. The troponin T level were elevated mainly because of significant myocardial muscle injury. This was a probably immune-related injury, was supposed to be the main mechanism causing this viral-induced myocardial injury. So dyspnea with fever and cough is to be considered as COVID-related unless proved otherwise. And not only lung, but always look for the heart conditions also. Thank you so much. I've given you a small presentation of a real-life case, which came up in the last week only. So medicine is a science of uncertainty, but it is an art of probability. So whenever you see a COVID patient as a cardiologist, we should always be very suspicious about myocarditis. Thank you so much.
Right. We thank you, Bhupen. That was really a quick summary as to what's happening in COVID days to heart. So initially, I used to say, oh, COVID, don't ask me questions. But as time went, I realized that, yes, heart is also getting involved. And today you're putting heart as number 2 organ getting involved in all these. So there is a question already, just one question before we move to Dr. Prashant, that between cough and fever, what do you think is more for COVID than, and between the two, will you make a choice?
In today's era with COVID, I think fever is very important. If anybody complains of fever with cough, you should always suspect COVID is the first thing.
No, between cough and fever.
Infection, it could be because of many reasons. But cough with fever and shortness of breath, COVID must be in mind as the first differential diagnosis.
All right. I think there's nothing much to choose between fever and cough. I guess both would come in most of the cases for positive for COVID. All right. So we move to Prashant. Let's hear from you.
Well, should I start now?
Oh, yes, go ahead.
Well, I thought after this wonderful case of myocarditis, let me share some controversies in managing acute coronary syndrome, particularly in the COVID-19 era. And to be true, there is paucity of adequate data as of now. And the guidance is based on expert opinion and currently available publications. The publications have come from China, publications have come from Italy. There is one from Society of Coronary Angiography and Intervention, and there is our own also CSI publication, which is also very good. So I would recommend all of our colleagues and the audience that please go through the CSI document. It is also very well made. And of course the Chinese document, because they have the largest experience. Now, what are the challenges in managing MI patients during COVID-19? Well, first and foremost probably is the patient delay. Patient may not be able to get a vehicle. Patient may not be able to get transport to come to the hospital. And this is certainly creating a problem. And there is non-availability of a rapid nucleic acid test for COVID-19. And that is very important, because there is no way. Most of the tests take about 48 to 72 hours. And very limited number of centers of testing. I mean, in Nagpur, we have only 2 to 3 centers which are doing. And if somebody wants to do on his own, he has to send a sample to one of the centers. It will go to Mumbai or Delhi, and the report would come after 72 hours. And last but not the least, the most important thing is abnormal troponin values in these patients are very common. So troponin, we don't have, the message is very loud and clear. We don't have to chase troponin in these patients. I mean, troponin would come positive eventually, particularly in the sicker patients. So troponin only doesn't justify further evaluation from the cardiac standpoint. It is only if patient has justification from cardiac standpoint, meaning intervention or angiogram, that would depend only if you are clinically sure and ECG wise sure of a acute STEMI or so, or a non-STEMI. Now, a few days back, there was an article in New York Times, and it read the mystery of the missing STEMIs. And from whether it is Milan or Madrid or Massachusetts, everywhere the STEMI cases have gone down by 70%. We also had a similar experience in first half of that is the last 2 weeks of May, the March month. But in April, we got STEMI cases. But the first few days, we got very less STEMI cases. And Spanish group has also reported a drop of 40%. Similarly, US group, that is George Washington University Hospital, they have reduced number of cases. And they say it is rather viral myocarditis, which is presenting as acute MI. And patients are taken to the cath lab, and when they find there is no obstructive disease, then they come to conclusion because they were chasing more troponin. And there are some case reports of Takotsubo cardiomyopathy and spontaneous coronary artery dissection also. And so observation is there is less number of true STEMIs and increase in STEMI mimics, which is based on, of course, anecdotal information. And where have all the heart attacks gone is that. Now, broadly speaking, if you would like to have a very simplistic approach, we can classify acute myocardial infarction to 3 groups. Confirmed COVID patient who has developed a MI, a suspected COVID-19 patient because of the history which Dr. Bhupen has nicely, very nice chart, tick chart, which gives a clue that he might be having COVID infection, and a very low clinical probability. For clinical sake of discussion, A and B we take as together, and C as a different subset. So in Nagpur, we have most of the patients come into group C because A and B, we have patients typically in 3 clusters, and most of the patients have come through these 3 clusters. Otherwise, in general society, we don't have any phase 3 or phase 3 patients. We have very low clinical probability when a patient comes to acute MI, at least in our setting. Now, we also, particularly those of our colleagues who are interventional cardiologists amongst the audience, there are considerations for cardiac catheterization laboratory procedures, and there are guiding principles. We need to screen patients. We have to use this PPE, very important, particularly if you want to do an intervention, angiogram, and patient selection is also important. Now, April 13, latest article, which has come in circulations about reperfusion of STEMI in current era, says that fibrinolysis may be the best compromise of the prompt reperfusion for the patient with least resource implications in order to buy time, and till that time, a complete clinical picture can be made. And this is very important, particularly in our setting in India. If in a city the resources are used too much, and there are hospital beds are not available, probably fibrinolysis has a lot of role. Now, let me give an approach. This slides has been a little bit modified from the Peking Hospital, China, which they have given their approach, assuming that patients are either having potential risk or those are positive. So if you have a suspected STEMI patient who presents to you in less than 12 hours, and if there is no contraindication to thrombolysis, then you can straight away go ahead with thrombolysis in emergency room. And should the thrombolysis be successful, then you can go ahead with the COVID-19 infection screening procedure lab test. And I believe in months in days to come, we will have a very rapid screening test, and we can then, if it is positive, send the patient to the CCU. So thrombolysis in emergency room is a new concept, and this is as per the Chinese document just come in European Heart Journal. But let us say the patient has presented late, or thrombolysis is not successful. So you have already given medical treatment, and the next situation would be unsuccessful thrombolysis or a delayed presentation. Go ahead with the screening procedure test, lab test. If they are positive, the COVID-19 infection tests are positive, then transfer the patient to a designated medical institution which are designated hospitals for COVID patients. So in our settings, there are the 2 government hospitals which are the cath lab. So a positive patient probably referred to a designated. If the patient is negative and unsuccessful thrombolysis, delayed presentation, and you have clinical criteria, admit him to ICU, and then you can take him to the cath lab. So keeping in mind, there are certain poor candidates for fibrinolytic therapy, and these candidates are typically delayed presentation, large infarcts, and hemodynamic or electrical instability, where you have to use clinical judgment. So probably a small inferior wall infarct or a lateral wall infarct, thrombolysis may be superior, but a large anterior wall MI, probably intervention is a better option. And that would also depend upon what is the clinical picture respiratory system wise. If the patient has a large pneumonia, then of course the cardiac status or the cardiac condition takes a backseat. Similarly, we have an approach for a non-STEMI or unstable angina. So the approach is a little bit simpler. If the patient is non-STEMI, you go ahead with the TIMI or GRACE score. And if it is a high risk, yes, then you probably have to admit him and consider invasive strategy. But if it is a low risk or medium risk, then the senior cardiologist has to take a review. And if the potential for COVID infection is not there, you wait for the lab test till you stabilize the patient medically. And if he turns out to be positive, transfer to a designated medical institution. This is what the approach says as per the Peking institution, China goes, and partly it is applicable to our country also. Guidelines for suspected patient with contagion: PCI should be performed only to the culprit vessel, no heroics. In patients with respiratory distress, early intubation should be considered. Before shifting him to the cath lab, you should intubate him before you take him to the cath lab. And a single procedure room should be designated for care of patients. Airflow modified to negative pressure if possible. So this is a little bit controversial, but airflow should be negative. Now, personal protective equipment includes respirators, eyewear, face shields, caps, gowns, surgical gloves, and shoe covers. And this is very important, and everybody should know about all the procedures and use of negative pressure ventilation, reduction in droplets spreading, and that is very, very important. Sometimes we have to keep in mind that in the cath lab, you have to minimize operators and staff. Otherwise, you are used to a lot of staff in the cath lab. But in order to expose them less, in order to keep reserve staff, because should somebody get infected, then he's out. So you have to operate with less staff. So try to minimize operators in the cath lab. Patient selection, sometimes deferral of urgent diagnostic or intervention procedures in cath laboratory, particularly STEMI patients with severe pneumonia, because then conservative treatment is important. Non-ST elevation MI, low risk features, stabilized with medical therapy. Type 2 MI, myocardial injury with elevated troponin levels, sepsis, ARDS, all these 2-3 conditions, I think we should be on the back foot and not, shift him to cath lab and, try to treat him medically. Take discussing with your intensivist, the infection specialist. So the take-home messages are: for AMI patients with COVID-19, multidisciplinary team, which includes cardiologist, chest physician, a radiologist, intensivist, and the infection specialist. Very important. And a radiologist has a very important role to play. Should you have a 64-slice CT, then a patient, when he comes to you or in doubt, you can do a CT scan and 64-slice CT scan and get valuable information before you take a decision on shifting into a cath lab. So emergency intravenous thrombolysis is the first choice for STEMI. Very important. If thrombolytic therapy is contraindicated, refer to the local designated medical institution. For non-STEMI, treatment strategies to be based on Gray series stratification or TB score while awaiting results for nucleic acid detection. Thank you very much.
Thank you, Prashant.
Yeah.
So you think it's going to be a rebirth for the lytic therapy?
Yeah.
And those of us who have forgotten the lytic therapy and always do PAMI, they may have to relearn the different dosages of lytic therapy.
True. Absolutely
yes. True. So there are already a lot of questions waiting for both of you. But let me at the outset ask you, when you have an ST elevation, you must have scanned the results of the angiogram from Milan, and 70% patients had no obstructive coronary disease. I mean, they had ST elevation, but they did not have an obstructive coronary artery disease the way we see it in a acute infarct setting when we take them to primary angioplasty. So it's more of myocardial damage and not atherosclerotic burden or a clot on top of an atherosclerosis. And that's why I guess the lytic would be a simpler option in these cases. Also, it is avoiding exposure to a lot of the cath lab staff to the possible infection.
True.
So, yes.
I think sometimes from the ECG we can take certain clues. If the ECG ST elevation is not following a particular vascular territory, LAD or the circumflex territory for that matter, it might give us a clue. The echo might give us a clue that because at present in a place like Nagpur, we don't have many COVID patients. But let us say in a city where there are too many COVID patients, you should be very alert, and ECG findings of myocarditis, which includes ST elevation, which does not follow a vascular territory. That is very important. That might give us a clue before we really try to shift the patient to a cath lab. Because once you shift to the cath lab, then you have to, all the staff gets exposed, the cath lab gets exposed to the COVID patient. And that is very, very important. And this is the lesson we have learned from people from Italy and from, for that matter, from US also.
So my friend Dr. Dilip Bhoge is asking a question. Is use of steroids in the early phase, especially in early phase, is helpful in myocarditis?
There is no clear-cut answer about it. You have to see patient individually. Each patient is different, but there is no convincing data that steroid helps them. Like our patient, the one which I discussed, that patient also received methylprednisolone, but eventually died of sepsis. So you have to make your own clinical judgment. There is no current guidelines about it.
What is your own feeling that in which cases you would say, yes, maybe we go ahead, and in certain cases you would say no, big no?
If you ask me, if the patient has a very high-grade fever, very poor ejection fraction, nothing much to be offered, I will definitely offer him steroid therapy. Because I have discussed with some of my colleagues, the fever is so high-grade, they have given up to 5 grams of paracetamol and fever doesn't come down. Patient has significant tachycardia and all those things. So if the patient is very sick, high fever, poor LV function, high level of myocardial injury, then I might prefer giving steroid.
Okay, Prashant, Dr. Hore from your city, Nagpur, COVID-19 tests are not available in private hospital. And if unsuccessful thrombolysis, how to proceed in such a case in India? Day-to-day practice is, decision-making is difficult. Can you wait? Like if you have a patient in front of you who has got a failed thrombolysis, we always say, take this patient to cath lab immediately. And today we are trying to go back and say, oh, wait for 2 or 3 days for the reports to come. What would be your take on that?
I think it's a very good question. If you have a patient of failed thrombolysis and probably it is a large infarct, and a large amount of area at risk, then probably it is worth taking a chance shifting him to the cath lab. But many times you have a clinical judgment depending upon, meaning assuming that there are two ways of approaching this problem. If you are assuming that this patient is suffering from COVID or he is having COVID virus, is likely to be positive, then ideally you should refer him to a designated institution. Because
what will they do?
Pardon?
What will they do? Like you are in charge
in
of
a city like Nagpur, we have a designated institute, Government Medical College Nagpur, which has a cath lab.
Imagine you are in charge of that designated institute.
No, if I am in charge of designated institute, then we have to take all the proper precautions. The precautions are well notified in the guidelines.
But you will go to the lab.
Yeah, I'll take him to cath lab because it is so let us say it is a large infarct and thrombolysis has failed, and assuming that this is a COVID positive patient, assuming that the respiratory symptoms are not dominant, cardiac symptoms are dominant, then probably I'll have to take him. If I will only not take him to the cath lab if the respiratory symptoms are dominant and is having also severe respiratory symptoms and let us say severe pneumonia where respiratory care will take an upper hand, then probably I will take a back seat. Otherwise, I'll shift into a cath lab if I'm in a designated institute.
You said in your presentation that you would intubate the patient before you start the...
Yeah, if the patient is in respiratory distress, because doing that in the cath lab will be, risking our colleagues to the aerosols and infection. So it's very important that you intubate the patient outside before you take. And it also, you don't have to secrete more adrenaline while doing a procedure if the patient is on ventilator. That's our common experience.
What about ventilator? You would not put them on ventilator, right? I mean, from first month to third month now, the treatment of COVID, so-called pneumonia, has changed.
Yeah.
And many of them are saying that ventilation is not a great idea.
True. Ventilation, many, paper has been published recently when they have realized that those who were not put on ventilator for various reasons, for lack of ventilators or whatever, they did probably better. So,
can I make a comment about acute MI in COVID's era?
Yeah, all yours.
Why not?
I think as Dr. Hiremath has pointed out, 70% of cases which were suspected to have acute MI and coronary angiography did not show much of an obstructive coronary artery disease. So if a patient comes to you with fever, cough and shortness of breath, ECG shows ST elevation, patient might be having a little bit of chest pain, troponin T may be high, but absolutely no PAMI, absolutely no PAMI. The current recommendation is to thrombolize him. And if he's not settled with thrombolysis, you then take him for a rescue angioplasty. The reason for not doing PAMI is there are reasonably good number of chance that coronary artery may be normal. This was a mimicker of acute myocardial infarction in COVID. And in the process, you will waste the precious resources. Your cath lab staff, nurse, yourself, you will all require full PPE. Then you have to lock your cath lab and sterilize it. And now it has been recommended that it has to be done in a negative pressure cath lab. If you are doing it with a regular AC, you can do more harm. And if your patient becomes unstable while doing STEMI, PAMI, and if you have to intubate, that causes too much of aerosolization. So your whole staff is very much exposed to the risk. So unless you are strongly pushed to cath lab, you should never do cath lab things. You should thrombolize them. Results of thrombolysis are equally good. You can consider pharmaco-invasive therapy. Invasive means we can do it later on, not immediately, till your COVID result comes as negative and patient is still unstable. Then take him into cath lab. Otherwise, you are exposing yourself, your hospital staff, and maybe your whole full hospital will be quarantined. So it is advisable not to do PAMI.
And you may do one cath procedure and the lab will be closed for next few days.
Closed, yes.
Absolutely.
Yes.
True.
So the other thing, Bhupen, you introduced two new words. We all knew STEMI, but you called it a STEMI mimic, and you also call it a fake STEMI. I don't know whether you use it, but that is another word that is circulating in the market. So STEMI mimic and fake STEMI. So we are basically dealing with some kind of ST elevation, not PACA, and troponin are very grossly abnormal, and coronaries may be close to normal. So that, I guess, summarizes the picture of a STEMI mimic.
Correct.
Absolutely.
So Dr. Panchali from Jabalpur is asking, would there be any medico-legal implications for liberal approach towards stable non-culprit vessel in current scenario? I think either Prashant or Bhupen, you already answered a big no. I think Prashant said that he used the word no heroics.
No heroics.
Yeah, no heroics.
No
And
heroics.
mind you, all the guidelines have been given not in the context of this pandemic. So the guidelines may not be as applicable when the pandemic situation is there. So that's a very important sentence written. And we have to keep in mind now the pandemic is going on. So the conventional guidelines may not hold true in today's world. That is why these new guidelines have come all over, and from Italy, from China, from US. So, and I showed 13th April circulation paper. Reperfusion is the new thing. Reperfusion is the meaning the new way of treating. That is what the fibrinolytic therapy is the new way of treating AMI patients. It will all depend upon situation, I think, MSR, because in my city, Nagpur, most of the patients are, most of them who are coming are non-COVID. As I told you, there are only 50 patients till now, only one death. And all those cases which PAMI, which I did in last 15 days, have been true PAMIs, 100% occlusions and artery open. So we did not do COVID test, but all of them are doing well.
I think
in our
this
part of the world.
number of cases with STEMI, whether it's gone down, gone up, and so on, there is a lot of controversy.
Yeah.
And people who say that it has gone down, there are many others who say that people are just staying back at home. In fact, somebody wrote saying that COVID deaths will be dwarfed by the death of that will happen once the COVID goes away. There will be so many deaths because people stayed back at home despite myocardial injury. So they will be with LV dysfunction after 3 months or 6 months from now. So they would have sudden death. And also those stable cases, many of them did not get any preventive up-titration of the medication during this phase. So that's going to be a worry. And cardiologists probably will have to work 2 times once the COVID goes away. So there are some people who say that the number has truly gone down. Pollution going down was one of the explanation they said. Then somebody said the stress level are also gone down. People are staying at home, but I'm sure many of you agree that staying at home also is not easy. So it could be equally stressful. And people are basically not coming to the ER room. I think that is the fear. I mean, people say, we'll stay back, otherwise we'll get COVID and so on. So
they're scared of going to the hospitals.
Yes.
Society is scared of going to the hospital because they think they will catch COVID from the hospital.
So you, Prashant, talked about COVID presentation like Takashribo, and those who recover, what's your feeling? They're going to get a normal LV later, or?
I could read 1 or 2 cases only in the whatever literature I scanned, but one of the patient has recovered. One of the patients has recovered from that. Even in this case of myocarditis, which Dr. Bhupen showed the case, patient recovered, the LV recovered. It was the DIC which killed the patient, unfortunately.
Yes.
The left ventricle recovered.
Dr. Suresh Chimnani is asking role of immunoglobulins. You have any idea?
Yeah, role of it is evolving therapy. We don't have any control studies or anything, but they have tried in few patients. The results have been quite good. So initial results are quite good.
I think when you have such situations of fulminant myocarditis, you tend to get more desperate. The treatment becomes more empirical, more compassionate. So
Correct.
treatment is given on compassionate grounds. Treatment is given on empirical basis. So we really don't know what is the correct treatment for this myocarditis. And it is very well written that COVID patients, type 1 infarctions are very uncommon. All the infarctions are type 2, supply-demand mismatch or direct injury to the muscle by the virus. So direct injury. So that is the reason for the troponin elevation and not the type 1 myocardial infarction. That is why the angiograms were normal or showed only mild atherosclerotic disease in Western Europe.
So Dr. Sandeepan from Mumbai is asking, in case of life-threatening cardiac event requiring emergency coronary intervention in a patient tested positive for COVID. He's written only tested, but I presume tested positive for COVID. What would be long-term effect on the patient's prognosis? Will he improve or will he remain with permanent damage? Too early to say.
Yeah, and the correct approach to a cardiac event would depend on primarily what is the respiratory situation, what is the respiratory condition, how sick he is from the respiratory point of view. If he is having mild disease and his cardiac event is life-threatening, then probably in a designated institute you would intervene. But a patient is on ventilator or is having severe respiratory distress and he gets a small MI, probably fibrinolytic therapy also should be tried in such a patient.
As I understand, those who get a severe cardiac problem, they always have a major respiratory problem. Yeah. So it's never a big heart problem and small lung problem. It is big heart as well as big lung problem. So I guess if he recovers from lung, he may also recover from heart.
Sure.
But I think too early to say, and probably we'll have to wait. There's a question, COVID-19, does it spread by air? Anybody wants to answer that?
Yes, it can spread by air, yes.
Then cardiac complications, I think most of us have discussed already. But what are the other cardiac complications related to COVID? I guess arrhythmias are also there. Has anybody reported heart block and requiring temporary pacing and all, or just the tachyarrhythmias?
Mainly it is tachyarrhythmia. There were not many reports of the bradyarrhythmias or heart block.
Okay. And according to one paper, about 17% had arrhythmias. 17.
Good number of patients who develop arrhythmia.
Arrhythmias, yeah, 17%.
Okay, I think Bhupen, you would be in a better position to answer this. Is there any specific way to differentially diagnose shortness of breath due to 1, heart failure, 2, COPD, 3, COVID infection?
If you are confused between COPD and LVF, then do a simple pro-BNP. That is what we try to do all the time. But in COVID era, it is little difficult. So you might have to do a chest X-ray, you might have to do a CT scan, and pro-BNP can be elevated because of myocarditis also. So in COVID, it will be both. As you rightly said, heart as well as lung, both will be involved. But in a typical confusion between COPD and acute LVF, pro-BNP is more than sufficient.
Somebody also showed in recent article the amount of fat outside the heart, pericardial fat. And that also seems to go up on CT scan. So that is another way to diagnose cardiac involvement in COVID. I think we're coming to end of some of the questions, but is there going to be a strain difference, like a particular area gets cardiac problem, a particular area gets simpler COVID infection? Is it happening like that?
I'm not sure.
We have not seen so many COVID patients so far.
Yeah.
No, but if you see the statistics across Europe, I think Italy got the worst of sort of numbers as well as deaths. So I think it was really rampant, as well as probably they were more susceptible. Many say that the general age is over 80 years for many in Italy. So the number of deaths also was very high. Prashant, there is a question for you from your Nagpur colleague, Sunanda Chowji. She's asking, Prashant, what's your experience? Is number of ACS cases coming to you is really reduced? Severe cases will not stay at home. So,
yeah, as I told you earlier, in the last week of March, when the lockdown started, we did not have many cases. But from 3rd of April, we started getting a lot of acute myocardial infarction. Practically 1 AMI per day. I mean STEMI per day, almost. So last 8 or 10 days, we got about 8-10 patients in our hospitals.
I would imagine it's a big number, isn't it? I mean, I don't know.
My hospital is a new hospital. It just started 2 months back. Many people may not be aware of the hospital as well. So it's a reasonable number. And so I don't feel last 10 days or so, the number has gone down at all. At least it is the same, at least in my hospital.
Same with me. I mean, in Rubiol, the number seems to have gone down a lot for acute presentation, while the smaller nursing home from where I get references, they seem to have lots of patients. So I think it's probably a redistribution and not a true lowering of the numbers.
So, sir, are these patients getting thrombolized in these small nursing homes, or what is happening to these patients?
Why, even if they come to a nursing home with a cath lab, a hospital with a cath lab, we are still thrombolizing. I think that's on priority. In fact, I keep talking to my juniors, and I probably tell them that thrombolize, and we'll see how things go.
I think that's a
after
very balanced approach.
Yeah, I mean, if thrombolysis sort of stabilizes them, I think well and good. You may or may not do an angiogram also. There is another question from Dr. Tanzir Khan. Is there increase in mortality rate in post-MI patients due to COVID? So I presume this doctor is saying that it's a COVID case. Now he has got a MI. So COVID MI is more risky than a conventional MI.
Obviously, I think he has two problems. So obviously, he will have a more mortality.
Yes, I mean, he has additional lung, but even if you take pure cardiac, I would imagine that there is a muscle component involved when we are dealing with COVID ACS. So they would be more risky than a conventional ST elevation MI. Those who present in half hour with an ST elevation, you open the artery and they go home on the second morning with preserved LV function. I'm sure that's not going to happen with COVID MI. Then Dr. Abdul is asking a question from Nanded. Role of ACE inhibitors in post-MI remodeling in COVID positive.
I think if patient is already on ACE inhibitor, continue with it, so long as it does not have hypotension. So you continue. But don't start de novo. If a patient has come to you newly, then don't start it now in COVID era. But if he's taking it regularly without any hypotension, without any side effect, continue.
Absolutely.
The European Society issued a supporting document where they have cleared both ACE and ARB, and they have allowed them to continue. But, that one is more related to hypertension. People who have hypertension, should they change from ACE or ARB? Even there, the answer is no. So I guess there is no, you can continue ACE inhibitor if they're already on ACE inhibitor. So the next question is about chloroquine. How safe for long-term use, like in type 1 diabetes? Let me ask you before we go to answer this question. Patient is at home, well looked after. He's sort of self-quarantined. Just because he's diabetic, does he need to take chloroquine? My own feeling is no.
I don't think so. Yeah, I agree with you. Fully agree with you.
Yes.
There's a lot of
Only
side effects.
yes, only those who are hospital personnel in whatever capacity, and if he has diabetes, I think there is a strong justification. Also, elderly, even if they are not diabetic, I think there could be a justification if they are working in a hospital environment. So, what about medical treatment, the way we give for ACS? Are we going to continue like that? So, big dose statin, clopidogrel, aspirin, I think there is going to be no change there. So, it's pushing you back about 30 years. That's the impact of COVID on ACS at the moment. How you treated in mid-80s or early 90s. That's the kind of treatment you go for. I guess cardiologists are so notorious that they would continue to follow these patients very closely, and they would get them to a cath lab. I think it's a strong reason to get them to a cath lab. It's also for our understanding and also good for the patient. You can't say that if somebody has got COVID positive, that's the cause of his atherosclerotic coronary artery disease. COVID positivity could only be incidental. So every COVID positive need not mean that there is a myocardial component to that. Anything else? Samir, did we miss out on anything that we had planned?
I think we have covered most of the controversial points which are related to COVID, I guess, in my opinion.
So this adipose tissue on the pericardium, I think that is one thing which I was quite surprised with, but could be a very easy to see. I mean, you just put somebody under the scan machine and you start seeing the adipose tissue. So people who cannot get a quick test must remember that a chest X-ray can give you some clue. So you do that. CT would be even better, so you do that. The WBC count, the NLR ratio, that ratio is also very important. The ferritin levels, if they are going high, that is again important. And also the liver enzymes, if they are high, you're dealing with a more rampant kind of COVID activity. So altogether, it's not as easy as the earlier flu kind of epidemics that the world has seen. It's worth shutting down everything, stay at home, and keep chatting with your friends like this. So, are there any other questions from the? I think we have one more question. This is again from Dr. Dilip Bhoge. He wants to know the role of chloroquine as a prophylaxis. I think we discussed a little bit. Maybe Bhupen, you know more about it.
Only 3 indications. It is only for COVID patient or his family member who are looking after COVID in home quarantine, or
no, he's asking for prophylaxis.
Prophylaxis, yes, for a high-risk healthcare worker, not everybody. Those who are directly involved with the management of COVID patients, they must take prophylaxis of hydroxychloroquine, not chloroquine.
No. It also means that in every hospital, there may be some designated bed for COVID and rest of the hospital is functioning. So Dilip, to answer your question, I would feel all hospital personnel should take COVID prophylaxis. It's very difficult to say who is going to be positive tomorrow. So I think don't wait, and I think give it to all your medical staff, COVID. COVID positive or otherwise, you should be giving prophylaxis. In places where COVID testing facility is not possible, how to manage ST. Oh, I lost the question somewhere. How to manage STEMI. So COVID testing is not available. We gave you small hints like do an X-ray chest, do a CT scan. They are probably easier than to do COVID. But I'm sure in next few days you will see COVID testing will be very easily available. So if you do not have COVID testing today and you have an ST elevation MI, look around for these help. They may tell you liver function test, ferritin level, WBC count, the adipose tissue in the pericardium. These could be some of the ways in which you can diagnose COVID positivity. A question from Sanjay Gadekar is patients on ACE with upregulation of the receptors have more risk of MI or myocarditis.
Yeah, can you repeat the question?
Those who are on ACE, there is an upregulation of the receptors, and these people will have a high risk of MI or myocarditis.
No. There is no such data.
There is no data.
No data like that.
All of us continue to give ACE inhibitors on ARB. The ibuprofen has got a warning that we should not be using ibuprofen. Is there any special treatment in COVID-19? I think it is probably out of place. I don't know if you people are experts at treating COVID, but not the correct forum. So we'll skip this question, I think. So there was this gentleman, hospital consultant. He had a congenital PR prolongation, and he was told to take prophylaxis. So I told him you could take, because chloroquine is not going to affect the PR. It affects mostly the QRS duration and the QT duration. So all those who are on chloroquine, how often they should repeat their ECGs? Prashant, any thoughts?
Well,
because see, the prophylaxis is just once a week and one tablet.
yeah.
So whether it's really necessary for those who are on prophylaxis to repeat their ECGs, they can do one in the beginning. I would feel they can do one in the beginning, and it's such a small dose that it will get evened out in a week's time.
Absolutely. I agree with you.
All right, I think we take one last question. This is from Dr. Abdul from Nanded. Mechanism by which COVID-19 affects the heart. There has been a lot of discussion, and everybody feels that there is probably no direct viral action on the heart muscle. So it works the way it gets into the RBCs, releases the ferritin, and it's like carbon monoxide poisoning. So the blood has no capacity to carry oxygenated supply to various organs. Somebody wants to know, COVID is curable disease, question mark. So far, though, if you don't die, it's a curable disease. Let's put it that way. So we still don't know whether somebody will live behind with some kind of myocardial damage. That's a possibility. I guess lung improves completely. I mean, the X-rays improve, the CT scans improve, so they have probably a better measure to check the follow-up on lungs. So hopefully you would recover completely. Okay, Samir, final comments and we close.
Sure. Thank you, Dr. Hiramath. I think we had great deliberations on CVD management today. I thank Dr. Bhupen Desai and Dr. Prashant Jagtap for their excellent orations. My heartfelt thanks to Dr. Hiramath for navigating the discussion in such a way that the key messages were percolated to our delegates. We had more than 600 delegates across West Zone who witnessed this webinar, and my special thanks to them for sparing their precious time and for helping our patients fight this COVID scare.
Actually, there is a bombardment of the webinars.
Right.
So there are sometimes 4 webinars which you want to attend. And on that background, getting 600 people, I think credit should go to your team too, Samir.
Thank you, sir.
So congratulations to all the Zydus team for
Thank you. Thanks for
getting
your
all of us
They
together.
have worked hard.
Yes, absolutely.
They have worked hard in percolating the message. And credit to you, sir, MS sir, because you are such a wonderful moderator. So,
I'm sure anybody can do this job.
no.
Thank you, sir. Stay safe, stay healthy, and may God bless all of us. Thank you very much.
Thank you indeed. Have a good day.
Yeah, you too, sir. Thank you. Thanks,
Thank
Dr.
you.
Prashant. Thanks, Dr. Bhupen.